BC here for BC Nephro. I'm Dr. Brian Cronin, board-certified nephrologist and clinical specialist in hypertension. In my early years of clinical practice, I had a consult. Patient was hospitalized after a hip replacement with a wound infection. The joint was not infected. I was consulted for acute kidney injury. Urinalysis was abnormal with hematuria and proteinuria, and he also had palpable purpura, a vasculitic skin rash. We ended up doing a kidney biopsy, and the immunofluorescence on kidney biopsy showed IgA staining. So here we have a patient that looks like has IgA nephropathy with acute kidney injury, and there was a clinical therapeutic dilemma. Do we treat this patient with steroids even though he has an infection going on? Shortly after that, I was at the American Society of Nephrology conference, and a case was presented. The case resonated with me because I realized at that point this is what my patient had. So this is the topic of today's talk: infection-associated glomerulonephritis. Classically, infection-related glomerulonephritis was post-strep. So a patient, typically a pediatric patient, had a strep pharyngitis. A week or two later, developed hematuria with or without acute kidney injury, and had a good prognosis with renal recovery. Other causes of infection-associated glomerulonephritis were with prolonged bacteremias, either from endocarditis or VA, ventricular atrial shunt nephritis. Now, I haven't seen these cases. I think they're less common. The post-strep was a pediatric presentation anyway, and I'm an adult nephrologist, but with the more common use of antibiotics for strep pharyngitis, this appears to be less common. Although endocarditis still occurs, most shunts are actually VP, ventriculoperitoneal shunts, although they can become infected, are not associated with bacteremias. These cases always had to be clinically distinguished from IgA nephropathy and membranoproliferative glomerulonephritis, as they typically presented with hematuria with or without acute kidney injury in the context of an infection. However, kidney biopsy typically could distinguish, because with infection-related glomerulonephritis, you would see IgG along with C3 in a characteristic pattern on immunofluorescence, and IgA nephropathy obviously had IgA deposition. In 2006, there was a case series of staphylococcal-associated glomerulonephritis mimicking IgA nephropathy, and this is a presentation that we need to consider in our adult population. It more commonly occurs in older patients with underlying diabetes who are presenting with the staphylococcal infection, which doesn't necessarily have to be a bacteremia. It can be a cutaneous infection or osteomyelitis. The biopsy shows IgA on immunofluorescence, making it more difficult to distinguish. So here are some of the characteristics and ways to distinguish infection-associated glomerulonephritis, specifically the staphylococcal IgA dominant variant, from IgA nephropathy and C3 nephropathy, which is now understood as a variant of membranoproliferative glomerulonephritis. So clinically, they all can present with acute kidney injury, active urine sediment, hematuria, proteinuria in the context of an infection. Unlike post-streptococcal GN, the infection is often active at the time of presentation with the staphylococcal infection. The infectious-related glomerulonephritis typically has a low complement C3 level. The C3 is low in about 80% of these cases. In IgA nephropathy, C3 typically will be normal. In C3 nephropathy, the C3 also will be low. However, after the infection, after a period of approximately 8 to 10 weeks, by 8 to 10 weeks, the C3 will normalize in the infection-associated GN. The C3, as well as the hematuria, will persist in C3 nephropathy. The staphylococcal-associated infectious glomerulonephritis can also be associated with palpable purpura, a vasculitic rash, which can be seen in IgA vasculitis. And even 20% of patients apparently have positive ANCA seropositivity, making the diagnosis even more confusing. The biopsies will show some sort of proliferative glomerulonephritis on light microscopy, although there are some subtle distinctions. And again, in IgA, both IgA nephropathy and staphylococcal-associated immunofluorescence will show IgA, along with C3 often. C3 nephropathy typically only shows C3. Electron microscopy for infection-associated glomerulonephritis, both the traditional and the staphylococcal variant, shows something called subepithelial humps, whereas in IgA nephropathy, the immune complexes on electron microscopy are typically mesangial. Unfortunately for patients with the staphylococcal variant, of infectious glomerulonephritis, the renal prognosis is poor, particularly for patients who have background underlying baseline diabetic kidney disease. Steroids are not helpful. They have not been shown to have a decreased incidence in renal recovery, and they have been shown to have a significantly increased incidence of adverse effects. This is similar to the experience that we had with the patient I described. So in your adult patients with diabetes and a diabetic infection, acute kidney injury, this is an important consideration in your differential diagnosis. Treatment is going to be treatment of the infection and supportive. So that's it. Thanks for watching. If you found this video informative, please share it with someone else who you think might learn from the message. And also, if you made it this far, you might as well hit like and subscribe. It helps the channel, helps me get the message and educate more people. And also, please leave a comment. Let me know what you think of this video and what topics you want to learn more about. Check out bcnephro.com and Instagram, bcnephro.